Hi, my name is Kevan Herold. I'm a professor of immunobiology and internal medicine at Yale University. Here are my disclosures. I'm going to be speaking about the differences between exogenous insulin administration and beta cell secretion, the natural history of beta cell failure in type 1 diabetes, and I'll also be speaking briefly about the impact of ethnicity and familial relationships on that decline. I'd like to cover the effects of type 1 diabetes on alpha cells because it has relevance to clinical outcomes. And then lastly, I'll touch briefly on metabolic function and secondary and organ complications, specifically microvascular disease and hypoglycemia, and its relationship to beta cell function in type 1 diabetes. The islets of Langerhans rely on circulatory and neural signals to regulate islet hormone secretion in response to physiologic clues and the cephalic phase of insulin secretion. They can be synchronized to secrete insulin in a pulsatile manner from individual islets to create coherent oscillations in plasma insulin levels. Cholinergic activation of the parasympathetic pathway has a general effect on the release of islet hormones, including insulin and glucagon, in response to the vagal nerve stimulation. The activation of sympathetic nerves stimulates glucagon secretion and inhibits insulin secretion to boost glycemic levels. The sympathetic pathway that regulates the islets is mediated by the classic neurotransmitter norepinephrine and neuropeptides such as galanin. Glucagon secretion is regulated by both alpha cell intrinsic and paracrine mechanisms. Somatostatin is a negative regulator of insulin, glucagon, and pancreatic polypeptide secretion. And obviously, it's important that these somatostatin secreting delta cells are located proximally to insulin-producing beta cells. Islet blood flow is regulated by signals such as hormones and nutrients that can reach the islet vasculature from distant tissues via the bloodstream. In addition, islet perfusion determines communication between endocrine and exocrine cells and between different types of endocrine cells within the islets. There is bidirectional flow between the intra and extra islet vasculature. None of these physiologic features occurs with exogenous delivery of insulin. Beta cells secrete insulin into the portal circulation from the pancreas, where it is seen by the liver, and about 50% is extracted by the liver in the first pass. This greatly regulates the exposures of the peripheral tissues to insulin. Exogenous insulin, in contrast, is deposited into the peripheral circulation, where it is seen first by the peripheral tissues and the liver. These differences greatly affect the normal physiology, such as an inhibition of hepatic glucose production or even the uptake of glucose in the periphery. Insulin is released from the pancreatic islets in a biphasic and pulsatile manner in response to elevated glucose levels, as shown on the left side of this slide, in which you can see the pulsatile insulin secretion in response to meals, and the significant pulses are identified by arrows. Insulin secretion is pulsatile, being detected in response to meals, and even in the absence of secretory stimuli, these pulses can be seen. In normal subjects, the most prevalent pulses are post-meal insulin secretion, consisting of a dampened oscillation with 2 pulses after breakfast and 3 pulses after lunch and dinner, as shown here. Insulin pulses are less frequent and occur less frequently in the absence of secretory stimuli. Impairment in the dynamic insulin secretion release can have a severe influence on glucose homeostasis and related physiologic functions. Loss of the first phase and reduction of the second phase are features of both type 1 and type 2 diabetes and are depicted also in the loss of pulses, where there's reduction in beta cell mass, as shown on the right side in this study from Peter Butler. The loss of beta cell mass is associated with reduced insulin secretory oscillations. Insulin secretion is also reduced in type 1 diabetes. It occurs in a pulsatile manner in patients with type 1 diabetes with a brisk early phase as shown in this graph representing the calculated secretory responses in a patient with type 1 diabetes to a mixed meal and is compared to C-peptide levels measured in the plasma. Data from our group and others has shown that patients with type 1 diabetes have a significant insulin secretory reserve at the time of onset of disease, and on average, the response to a mixed meal is about 52% of the response of non-diabetic control subjects at the time of diagnosis. In most patients with type 1 diabetes, insulin responses generally reach a peak in their secretory rates within 45 meals of ingesting a meal. This is also the predominant pattern in normal control subjects. In other patients, the insulin secretory response is delayed, with peak insulin secretory rates occurring at 45 minutes or later after ingesting a meal. Insulin pumps, however, do not recreate insulin secretion, neither the basal secretion of insulin and its pulsatile patterns, as shown here, or in response to a meal, as shown in the blue curves. Type 1 diabetes is an autoimmune disease with a metabolic outcome. Preclinical studies have shown the ability of T cells to kill insulin-producing cells. The exact identity of these cells is still under investigation, but most work suggests that CD8 positive T cells kill beta cells. Modulating immune cells can avert autoimmunity. Examples of drugs that have been able to do this include teplizumab, the anti-CD3 antibody, anti-thymocyte globulin, CTLA-4 Ig, alefacept, LFA3 Ig, and rituximab, anti-CD20 antibody. Thus, the killing of beta cells is the cause of type 1 diabetes. Measuring this outcome reflects this pathologic process. Now, to understand the importance of physiologic insulin secretion during progression of disease, let me first just summarize our concepts about the stages in progression of type 1 diabetes. The first stage, which is heralded by the identification of 2 or more autoantibodies in the serum, identifies individuals in which the autoimmune response has been initiated and eventually will go on to develop type 1 diabetes. These individuals are clinically silent. The only way we would know that they exist is by the finding of autoantibodies. When there is some impairment of beta cell function, we designate this as being stage 2. The impairment in beta cell function is identified during provocative tests such as a glucose tolerance test. Again, these individuals do not have clinical type 1 diabetes, but they do have some impairment in beta cell function and the presence of autoantibodies, which indicate they are well on their way to progressing to overt clinical type 1 diabetes. The risk of developing type 1 diabetes for individuals at stage 1 is about 44% over 5 years, whereas it's about 75% over 5 years for individuals with stage 2 disease. Stage 3 disease is overt hyperglycemia that we recognize clinically, and it may be associated with diabetic ketoacidosis or may not be associated with diabetic ketoacidosis and is picked up by identification clinically of clear hyperglycemia. Stage 4 is what follows and leads to the complete or near complete loss of beta cell function. And as shown on this graph, immune therapy may change the course of that progression of stage 3 to 4 diabetes. The dynamics of insulin secretion are also impaired during progression of type 1 diabetes, and this is illustrated from these studies by Eli Ferranini that was done using TrialNet data, in which he found there was impairment in insulin secretory responses about 1.5 years or so before the diagnosis of overt clinical type 1 diabetes. So even prior to the onset of clinical disease, there's impairment in beta cell function. These functional impairments are important. And the evidence for this comes from these studies that we did, in which we are looking at progression to type 1 diabetes and the changes in insulin secretory response during that progression. What we did is identified individuals at stage 2 diabetes. In other words, some impairment in glucose tolerance, but not overt disease, and the presence of 2 biochemical autoantibodies. We brought these individuals back for rescreening and found that some of the individuals came back and had a normal oral glucose tolerance test, even though it was abnormal previously, whereas some of the individuals continued to have the abnormal glucose tolerance test, and some of the individuals, interestingly, came back and had a normal oral glucose tolerance test. We found that what differed between these subgroups that came back, those with normal, abnormal, or diabetic oral glucose tolerance tests, was not the total amount of insulin secretion during the oral glucose tolerance, but what was different were the dynamics of insulin secretion, as shown on the right part of this slide. Individuals who came back with a normal oral glucose tolerance test secreted a greater percentage of the insulin in the first hour of the test compared to those who came back with abnormal or a diabetic oral glucose tolerance test. In other words, secreting insulin in a normal physiologic pattern in which the majority of insulin secreted in the first hour was associated with recovery of glucose tolerance, whereas those who continue to show delayed insulin secretory responses had a abnormal or diabetic oral glucose tolerance test. So the dynamics of insulin secretion are very important. This is further illustrated in this data, again from TrialNet, in which the early C-peptide responses were shown to be significantly impaired in individuals who progress before they develop actual diabetes. These are data from 2 studies. On the left side, we're looking at data that was put together from the Pathway to Prevention trial in TrialNet, in which you can see that the early C-peptide response is impaired. The red line indicates normal early C-peptide responses. And you can see that this occurs even before there is progression of overt hyperglycemia, shown on the left panel here. On the right side, we're looking at the total C-peptide response over time to oral glucose tolerance tests. And you can see that it's relatively well preserved, as shown in the black line, but only begins to fall as overt hyperglycemia appears. Now, how do changes in C-peptide during progression to type 1 diabetes vary by ethnic groups? Is there a difference between the ethnic groups and with or without a family history of type 1 diabetes? So let me first point out that the data would suggest there's really not a difference between individuals who are Hispanic or non-Hispanic. And that's shown in this data that, again, is from TrialNet, in which individuals who are Hispanic or non-Hispanic white individuals were compared for their C-peptide responses, shown on the right, over years before and after the diagnosis of diabetes. What you can see is that in Hispanic and non-Hispanic whites, there are differences at the time of onset of diabetes, a lower fasting C-peptide in non-Hispanic whites compared to Hispanic participants, and a greater frequency of diabetic ketoacidosis in Hispanic versus non-Hispanic whites, and a subtle difference in age. However, if you look at the progression of disease on the right side over time, there really is no difference, and ultimately individuals get to the same place. A similar type of scenario is seen in those who do or don't have relatives with type 1 diabetes. You can see at the time of diagnosis, there's a difference in age, lower age in individuals with a relative, and a slight difference and a difference in the frequency of diabetic ketoacidosis, which is more frequent with sporadic versus those with relatives with type 1 diabetes. And the hemoglobin A1C is also different, suggesting that those with a relative may be identified at an earlier stage of the disease. But if we follow individuals over time and look at the frequency of remissions, we don't have data showing the actual C-peptide data, but if we look at the frequency of remissions identified by this measure IDA1C, which is a insulin dose adjusted hemoglobin A1C, a value of less than 9 indicating a partial remission. If you look at the frequency of partial remissions, it's about the same in those with and without a family history of type 1 diabetes. Now, what about alpha cells in type 1 diabetes? So work that had been done years ago by Phil Cryer and others described how there was dysregulated glucagon production in type 1 diabetes. Under normal conditions, there's reduction in insulin secretion in response to lowering of glucoses, but and an increase in insulin secretion when glucose levels increase. And these are associated with an increase or a decrease in glucagon, respectively. However, in type 1 diabetes, there's no reduction in glucose levels and when blood sugars are low, because insulin has already been given exogenously. And there's no increase in glucagon when there is hyperglycemia. So the exact opposite of what is achieved physiologically occurs in patients with type 1 diabetes. Now, is there a basis for this? And more recent studies from Al Powers and others has shown that indeed there are alterations in alpha cells, including altered alpha cell gene expression, such as reduced ARX, reduced MAF beta, and also some secretion of NKX 6.1 in alpha cells, which normally is restricted to beta cells. Interestingly, in these perfusion studies from a patient with type 1 diabetes, beta cells responded normally, but when corrected for the total alpha cell mass, there was reduced glucagon secretion in the patients with type 1 diabetes. I think clinically this is clear. When we look at glucose counterregulation in normal patients in response to a injection, a bolus of insulin on the top panel here, where you can see there is glucose counterregulation, whereas in patients with type 1 diabetes who receive a single bolus of insulin, there is not glucose counterregulation. Glucose levels fall and stay low. So there is both an impairment in beta cell function, obviously, which leads to the diagnosis of diabetes, but in addition, there is impairment in alpha cell function. Now, does correction of the beta cell function improve alpha cell function? Well, the limited data that we have about this would suggest yes. This trial of alefacept in patients with type 1 diabetes that was done by the Immune Tolerance Network suggested that in patients in whom there was improvement in C-peptide, shown on the left side, where we're looking at the C-peptide response to a mixed meal, and the drug-treated people in red compared to control in blue, there also was reduction in significant hypoglycemia, suggesting a link between improvement in beta cell and potentially alpha cell function. Now, what about the secondary end organ complications of diabetes and C-peptide? And the analysis that that sort of triggered this whole area, which is shown here, which is from the DCCT, in which John Lakeen looked at the relationship between secondary end organ complications, in this case, on the left panel, eye disease, and on the right table, other end organ complications such as microalbuminuria and renal disease, and found that individuals who retained at least a level of 0.2 picomoles per ml seemed to have reduced risk of secondary end organ complications. This data, recently published from patients in Scotland, describes the relationships between residual C-peptide on the x-axis and glucose control, hemoglobin A1C, insulin use, retinopathy, and hypoglycemia. It shows that the relationship between C-peptide and these other measures are gradual, with the exception of hypoglycemia, in which there's protection even to the very low levels of residual C-peptide. The recently published data from the EDIC trial, the Epidemiology of Diabetes Interventions and Complications, the follow-up of the DCCT, showed a similar phenomenon, although the relationships between hemoglobin A1C and other complications were less profound. The proportion of subjects with a history of severe hypoglycemia was lower with high and intermediate residual C-peptide concentrations than with low and no residual C-peptide concentrations. The p-value was highly significant. These were individuals who had diabetes for in excess of 35 years. And so it shows how this relationship between residual C-peptide and hypoglycemia is maintained even years after the diagnosis of type 1 diabetes. To look at this in another way, this graph describes the relationship. The left y-axis refers to clinical benefit and the relationships between time on the x-axis and residual C-peptide on the right axis. The loss of C-peptide, shown in the dotted line, occurs over years. When C-peptide levels are relatively preserved, either before the diagnosis or in new-onset patients, as shown here, the hemoglobin A1C levels remain well controlled as a result of the retained beta cell function. However, after 1 to 5 years, when C-peptide levels decline, the clinical significance of the C-peptide levels also decline, and hemoglobin A1C levels may increase. In long-standing diabetes with low but detectable residual C-peptide, the effects on hemoglobin A1C are insignificant. However, the relationship between C-peptide and hypoglycemia is more acute, as shown by this red arrow. Retention of C-peptide is associated with reduced risk of severe hypoglycemia over a very wide range of C-peptide levels. It is only with the very low levels of C-peptide that this benefit is lost. So in conclusion, exogenous insulin delivery is not the same as endogenous insulin secretion. There is a continuous decline in C-peptide that begins prior to and continues for years after the diagnosis of type 1 diabetes. Early insulin secretion is affected. The decline is similar in those with and without a family history and in Hispanic and non-Hispanic white patients. There also appears to be impaired alpha cell responses, which may lead to the frequent complication of hypoglycemia with insulin treatment. Available data would suggest there is an inverse relationship between beta and alpha cell function. Retention of C-peptide is associated with reduced rates of complications of type 1 diabetes. At higher levels of beta cell function and early in the disease course, glucose control, which is linked to microvascular disease, is improved. Even lower levels of retained beta cell function are linked to reduced rates of severe hypoglycemia. Thank you very much.